All right, this is Biomechanics Lab. This is going to be our last lecture over Chapter 1 on joints. All right, so let's talk about joint classification by structure and function. We have this neat little table here, and we have three structural classifications of joint. We have what are called fibrous joints, we have cartilaginous joints, and synovial joints. Now, fibrous joints are basically going to be lined with fibrous connective tissue, whereas these are cartilaginous are obviously going to be cartilage lined. And then synovial joints are very different, and we'll talk about that last. We also have functional classification, and the functional classification here has to do with the degree of motion of the joint. So our first type is called synarthroidal. I usually call this synarthroses. If you see the suffix throses, that or arthroses, that tends to mean you're talking about a joint. So if you talk about arthritis, that is inflammation of the arthrosis or joint. So you got joint inflammation. Okay. So this is synarthroses. Synarthroses have no movement. So these are joints that have no movement. Okay. Remember, all a joint means is that you have two surfaces that come together. So for example, we would say that there's technically a joint between Canada and the United States. There's a joint between the United States and Mexico, right? But that joint doesn't move, right? That's sort of like what a synarthrosis is. It doesn't move. It's just there for structure. Amphiarthroses, those are joints that are slightly movable, okay? They don't move much. Certainly not like your shoulders or elbows or things like that. They only move a little bit, and you wouldn't really even think they move that much, but they have a little movement. Then diarthroses, these are joints that are freely movable. These are the joints we're used to thinking about when we talk about joints of the body. So let's go into these very quickly. So first of all, of note, all synarthroses are fibrous joints. And the best examples of these are sutures and gomphoses. A suture is a joint that connects the bones of the skull. Whenever we are born, it turns out that our skull is actually a bunch of bones that have not yet fused together. And it doesn't occur until a little bit later after birth that these joints actually solidify and the skull bones become completely connected together. Okay? And those joints are called sutures. And they're, like I mentioned, those are fibrous joints. Okay, because they are joined with fibrous connective tissue. Another example of this are gomphoses. Gomphoses are basically, for all intents and purposes, they're joints that basically hold your teeth into your gums. Okay, again, they're held with fibrous connective tissue. All right, and those have no movement. The only way you could possibly move these is if you get your tooth knocked out by a punch. Okay, so amphiarthrosis. These come in two flavors: fibrous amphiarthroses and cartilaginous amphiarthroses. Now, amphiarthroses have a little bit of movement, but not much. So let's take a look at the fibrous one. The fibrous one is called a syndesmosis. Okay, syndesmosis are these fibrous connective tissue that joins your radius and your ulna, for example, in your arm. Okay, so we have in our forearm a radius bone and an ulna. And there is a syndesmosis, a bundle of fibrous connective tissue that joins those two bones. It turns out that it is slightly movable, not to the degree of, say, the elbow joint, but it does have some movement. Okay? If we're talking about cartilaginous amphiarthroses, we have two kinds: symphysis, and synchondroses. All right, if we're talking about symphysis, the best example is the pubic symphysis, which is going to be a cartilaginous disc. It's actually fibrocartilage, and it's going to join the two hemispheres of the pelvis on the inferior side. Okay, again, has slight movement, not much though. It's made of fibrocartilage. Some people refer to it as the interpubic disc. Okay. The final type is going to be the synchondroses, which are going to be the costal cartilage. Okay. Costal cartilage is going to be cartilage that's going to connect the rib to the sternum, and this is a synchondroses. And these are important, and the reason they're slightly movable is because it turns out that that cartilage can actually move a little bit when you inhale and then exhale. It turns out that we know that when you do a deep inhale, you get all that air in your lungs expand, which also causes the rib cage to expand a little bit too. And then when you exhale and your lungs decrease in volume and size, then those joints basically contract back, and the rib cage contracts as well. Okay. Now, we're talking about diarthroses. Those are all synovial joints, and that's what we are going to be talking about in biomechanics lab. All right. So this is the general structure of a synovial joint. Now, they are technically diarthroses, but everyone is going to refer to them as synovial joints. That's the typical term, so that's what we're going to use. Okay, so the synovial joint is going to have two bones that are interacting. Okay. And typically we have these structures in here. First of all, we have articular cartilage. As I mentioned in the last video, we have hyaline cartilage that encoats the ends of the bones, so the epiphyses of each bone. And rather than having the two bones themselves interact, which would cause friction and osteoarthritis, etc., and pain, not to mention, the articular cartilages interact and they don't cause friction. They don't cause pain, so that's good for us. Also, the joint is encoded by a synovial membrane, and within the synovial membrane, between the bones and that membrane, we have fluid, and the fluid is provided by the synovial membrane. It is called synovial fluid. And also we have bursa, which also contain fluid that help lubricate the joint and prevent unwanted or unnecessary friction. Okay. Also, what we need to understand is we have a synovial membrane which lines the inside of the capsule, and we have a fibrous capsule which is the outside, and together these are called the joint capsule. Okay? Not to mention, but it's kind of obvious, we also have blood vessels that innervate the area to provide nutrients. And also remember, and I haven't really gone over this yet, but we'll go over it next week when we talk about muscles, that remember, how do we get movements of bones? For example, if I move my arm up, obviously a bone is moving. The joint's either increasing its angle, decreasing its angle. Well, it turns out that a muscle pulls on the bone. Muscles contract, and they provide force that pulls a bone in some direction. But the muscle typically does not attach directly to the bone. There's an intermediate structure, or we can call it the middleman. It's called the tendon. So a tendon is an indirect connection between the muscle and the bone. In other words, we would say the muscle pulls on the tendon, which pulls on the bone, which moves the bone. So this is the tendon right here. Okay, so hopefully that makes sense. We also have different classifications of joints depending on what kind of motions they allow. And without going into too much detail, we'll look at this slide, which gives you a table of the various types of joints. We can have hinge joints, pivot joints. We can have a ball and socket ovoid. We can have gliding joints, ball and socket spheroidal, and saddle joints. Now, when we're talking about hinge and pivot joints, those are what we call uniaxial joints, meaning they only permit motion in one plane. Now, it could be a different plane. For example, hinge joints allow flexion and extension in the sagittal plane. Remember back to the first lecture, when we talk about flexion and extension, those have to occur in the sagittal plane, right? Okay. If we're talking about pivot joints, they also allow only motion in one plane, but it happens to be the transverse plane. So if it's the transverse plane, remember you would expect those to be rotations, and sure enough, that's exactly what we see. We also have these, now they call them ball and socket ovoid. These are typically called condyloid joints. So we're going to use the term condyloid. Those permit motion in two planes, for example, the sagittal and frontal plane. And if they promote motion in the sagittal, we would expect flexion and extension. But if it's frontal, abduction and adduction. Remember, those are different terms depending on which plane you're moving in. Okay? Also, keep in mind, the number of planes that you can move in for that joint defines what degree of axiality is. Sagittal and transverse, so these are just one for each. So these two joints, hinge and pivot joints, are uniaxial because they only permit movement in one plane. Condyloid joints permit movement in both sagittal and frontal, so they are biaxial. The last three joints, which are gliding joints, the true ball and socket joints, and saddle joints, these are multiaxial. And really you could probably call them triaxial because each of these is going to allow movement in basically three different planes, okay? And so you can expect if they're going to allow motion in all three planes, you're going to be able to do all these motions. Flexion and extension, which would be sagittal, abduction and adduction, which is frontal, and the rotations, which are transverse, okay? So make sure if you had a question in some way regarding, hey, I've got this joint. I don't tell you what the joint is, but I can tell you which planes it allows movement in, you could tell whether it's uniaxial, biaxial, or multi-axial. Also, if you had a question that said, hey, I've got a joint and it only permits movement in the sagittal and frontal plane, which type of joint is it, A, B, C, or D? Well, there's only one joint that allows movement in two planes. So the answer would be condyloid joints. Okay? So just kind of basic questions with respect to that. Okay? All right. And we've got one more concept to go over here. And this concept is the relationship between joint stability and joint mobility. All right. So let's think about this for 1 second. Okay? I've got, say, the knee joint. Okay? The knee joint, I think we know it is a very unstable joint. I mean, you've heard of tons of knee injuries that occur in college, pro sports, whatever. But the knee joint is low stability. And that usually is going to imply when you have a low stability joint, it has very high mobility. And that's because mobility and stability have an inverse relationship. If one goes up, the other goes down with respect to joints. So for example, a good example of a very stable joint would be, say, the sutures in your skull. Now I know we don't typically talk about those in biomechanics, but this is a good example. Sutures are very stable. I mean, they're not going to come apart. I mean, you can crack your skull, but they typically don't crack at the sutures. They're very stable. Probably the most stable. But do they allow mobility? No, they have zero mobility. So they have exceptionally very high stability, but no mobility. We look at another case, say the hip joint or the knee joint, even the shoulder joint. Those have a huge degree of mobility, so that tends to decrease their stability. Okay? So if we're talking about joints that are typically low mobility or high stability, they're usually going to be involved in providing architecture, so they're going to be structural. They can be cartilaginous, like we talked about the pubic symphysis or the synchondroses. That occur in the ribs. They can be ligamentous and connective tissue. Okay, we talked about sutures and gomphoses. Those are have fibrous connective tissue. If we're talking about ones that have higher mobility, they're going to have lower stability. Those are going to be what we call mostly our synovial joints. They're going to provide strength. They're going to provide movement and all that good stuff. Okay. One other thing, even if we're just talking about diarthroses or synovial joints, okay, we can have different degrees of mobility and stability there. For example, if I was, say, to compare my knee joint, which happens to be a very unstable and highly mobile joint, to the joints in my foot that would allow me to plantar flex or dorsiflex my foot, the dorsiflexion and plantar flexion, the joints in the foot that allow that, don't have as much mobility. So that usually is going to imply they're going to have much more stability. Those are also synovial joints, whereas the knee is going to have very high mobility, which tends to lead to its high instability or low stability. All right, so make sure you know this relationship with respect to joints. That's going to be it for Chapter 1. We're going to have a shorter lecture over Chapter 2. Make sure to watch that before you come to class next week.